Hi everyone, welcome to Nityal Physio podcast. So we have an eminent person who is a physical therapist with 10 years of experience in low back pain, and his core interest is in treating sciatica. And Dr. Ashley, let me introduce to my speakers. And Dr. Ashley has founded ifixyoursciatica.com, and he is the one who is into the most eminent podcasts on sciatica itself. So we have been following your podcast from so many years. So since it is a similar area of interest, so I'd like to see Dr. Ashley's perspective on how to treat sciatica as well as how to manage people with discogenic part as well as the peripheral part. Dr. Ashley, welcome to our podcast.
Thank you for having me.
So I would like to know regarding your perspective on why you started sciatica, why the interest in sciatica has come up.
Yeah, I would say it all was born based off of a position of wanting to help people. I know that for many of us who've gotten into this profession, the focus was actually to help people, whether it be to rehabilitate from an actual injury, a surgery, even from something like stroke. And throughout the years, I've been actually able to work with populations expanding the entire rehabilitation spectrum. What got me into sciatica itself was throughout my training, I went through the more of the McKenzie based and Maitland based treatment protocols, where listeners, if you are not familiar with those two, really the focus is actually rather than addressing what structures are the issues, we're really looking at, well, what is the patient, the person who's dealing with pain actually going through? And they're going to be giving us the answers. And I found it to actually be a very intriguing way to treat and manage patients for a couple different reasons. Number one, I remember graduating from school and having a taste of a patient centered model of care where, again, the patient's going to tell you exactly what they need to do when it comes to healing. But unfortunately, just due to the system that was going on, I didn't necessarily have the time nor opportunity to actually sit down and think, well, what are these patients going through? So I end up getting caught up into the same typical, well, I'll call it the same typical approach where someone comes in with back pain or someone comes in with sciatica pain. And I had a go-to list of 10 to 13 exercises that were designed to actually help improve the pain. The challenge was a lot of these patients didn't get better in 6 to 12 weeks. And it made me start thinking, well, what is the missing aspect of this treatment protocol? And so I realized that it wasn't necessarily it didn't necessarily have to be a specific protocol. I think one of the misconceptions that we learn about from a pain standpoint is the fact that pain is going to be due or related to an actual specific tissue injury. And we have a specific set of exercises or stretches that will actually address the specific tissue. And throughout the years, I realized that a large part of the pain that we deal with is really more so an individualized experience. And what that means is, say, if you have 5 people who've been dealing with sciatica pain and we give them the same exercise, they could actually be entirely different outcomes between person to person. And so it started me to getting me to answer or ask these questions early on in my career. I would say around year 3 and 4. And then from there, I realized that a large part of the people who were coming to see me, I wasn't their first physio that they were actually seeing. It was probably their third or fourth, or it was their final hope before they actually had surgery. And so at that time, it made me look at, well, why aren't these patients getting any better? So I went back into my training, into the aspect of asking more questions about the pain that we're dealing with. And throughout the years, I realized that I had particular success with people dealing with sciatica pain. And so it really was more of a natural progression of my career where I was actually able to say, okay, this is the thing that I'm going to work on. Now I know, now I'm able to, work on other conditions as well. But from a sciatica pain standpoint, I find that the breadth of knowledge is so wide and so vast, and that there's so many opportunities for people to get help. There are some folks who get better in one visit. There's some folks who are going to get better in about 6 to 12-ish months because of the fact that we're still trying to figure out why are they experiencing the pain in the first place. And both you and I know that typical tissue healing time is about 12 weeks. And if someone's dealing with pain for longer than 12 weeks, what that means is that whatever needs to be healed is healed, but there's still some sort of irritating stimulus that's happening. And so that's pretty much a long story short of what got me interested in the sciatica spectrum, sciatica realm.
Oh, that's great. And regarding your patient-centric approach, so how do you see in terms of patient-centric approach for sciatica?
So my approach is the following. I would say the approach, I like to say from a consistency standpoint, it's important that we do have a specific process. So my systematic process is very similar to a lot of other physical therapists, but I'll share with it because I think it is important. Number one, we need to ensure that we rule out any sort of medical red flags. We need to make sure that the sciatica pain that we're dealing with is actually caused by some sort of structure, not caused by a fracture, not caused by a tumor, things that would actually be outside of my control. No stretch or exercise is going to fix a fracture. No stretch or exercise is actually going to fix a spinal tumor.
Correct.
And there are a series of questions and tests that we can do. The most important part is actually addressing, are we actually dealing with a true mechanical issue, or is there something more sinister? So being able to rule that out specifically, questions like, have you been dealing with any sort of changes in your bowel or bladder function? Have you noticed any unexpected weight loss or weight gain? Have you been experiencing night sweats, which night sweats associated with these symptoms and weakness can also be indicating something a little bit more outside the scope of what I can provide. And so all of these questions, as mundane or as repetitive as these questions are, these are very important for me to answer and ensure that we are not dealing with something that is outside of our control. That's going to be number one. Number two, what we're going to go through is actually, as I call it, a subjective assessment. So being able to actually go through a full history on how the pain actually came on. And what that actually does is a couple things. Number one, it actually helps me figure out, was this an actual traumatic issue? Was it that they slipped and fell, or was it more of a repetitive issue? Were they doing an activity for a long period of time or multiple times? And so when I'm asking those questions, it helps me figure out, all right, well, if it's trauma, then we're just going to have to heal from that specific trauma. There really wasn't much that we could do if you tripped and fell. Perhaps our focus is on tissue protection as well as making movement safe again. What I find is that that traumatic experience is what we'll call a little bit more straightforward. It's a little bit easier to manage because you know the exact moment that the pain started to happen. So we can start looking at, okay, that's the event. On the other end of the spectrum, where we're looking at more, we call it like an insidious onset, where someone woke up with this pain, or they just started to notice that the pain started to come on a little bit more gradually. That information is actually telling me that we need to actually look at what are the behaviors, what are the activities that these patients, what are they doing that is actually contributing to the pain that they've been dealing with. And so from there, as we're getting the story of how the pain came on, what were the events leading up to it, another series of questions gives me an idea of the level, the degree of how much this pain is impacting their lives. So if someone's experiencing pain when they're laying down, questions such as, are you able to sleep? And really the idea is to be able to collect all this information, right? And then I think the most important part is ultimately people come to us for pain relief, right? So I think one of the most important questions, yet undervalued questions, is tell me some of the positions or exercises or things that you're doing that actually make you feel better. Because that gives us two things. One, it kind of gives us an idea of what type of treatments would actually be beneficial for the patient. That also can give us a little bit more of an idea of what could be a contributing factor to the pain. Could it be discogenic? Could it be arthritic? Could it be something else, right? And then the same goes into identifying what are the activities that actually increase your pain. So then that way we can look, all right, do we need to do an activity modification, or do we actually need to remove that activity completely out of the daily routine until the patient feels safe enough to return, right? And so we have red flags, we have the subjective, kind of figure out how did this all start, and then we have the activities that feel good, the activities that don't feel good, and then from there we're actually able to determine what can be the source of pain, and how can we actually make that person feel better.
Nice. And how we get here is we get referrals from orthopedic surgeons. So they refer, and how we usually do is we see the same approach, but we don't get that patient centric approach as of such because we are just working on that. So usually the perspective of a patient is they'll come, they'll see what therapy has to be given, and they'll come with a prescription. So they come and they say that these are things that has to be done by a surgeon. So we give our input to the surgeon and we go along with that. So few we may give and few may not give. But like you said, it may take one session or it may take consecutive sessions. But the issue here which we get is follow up. We don't get the sequence of 12 sessions to 20 sessions. It may be either lower or it may be either longer. They come for a week and they come for 5 sessions straight. So the issue what we face here is we don't have the 3 months follow up or 4 months follow up where we see from day one to fourth week or the day one to third month how their pain is subjected to change. So that we lack here because that is one perspective which we wanted to work on, and that is a research which we are going through because we want patients to come continuously for us for at least 3 months. So we'll see how their activity is increasing and how their functional activity as well as physical activity is improving. Thank you, Dr. Ashley. And one more question regarding that. So now when you're trying to treat patients with sciatica, so we you told there is McKenzie and there is Mulligan. So usually there is a notion that everyone with discogenic, we straight away go to McKenzie because it's one of the widely used technique. So what's your take on McKenzie? And if you're using McKenzie technique, what are the things that you have to see? Whether you will be going with straight away flexion or will you go away with directional preference of flexion or extension?
Great question. I think it's important to understand that Mackenzie itself, although he accidentally found the power of back extensions and prone press ups for the treatment of, say, discogenic issues. Um, it's not the only way to actually treat discogenic pain. And I think that it was one of the challenges. And I remember coming across a research article where they actually had patients be in an MRI and actually complete the actual prone press up. And it was all theorized that a prone press up or a back extension would actually be centralizing their disc herniation and disc protrusion back and towards the middle. The research actually showed that that wasn't necessarily the case. Although it might seem like it would make sense from an anatomical perspective, it wasn't like that all the time. Unfortunately, I don't think this article actually made it to see the light of day. I don't think a lot of physios actually had the opportunity to see this research. And what ends up happening is the fact that they end up actually treating just the MRI and not the patient itself. And really what Robin McKenzie was focusing on was the fact that, yes, there is a directional preference most mechanical low back pain or most mechanical based sciatica pain. But the thing is that it's still based on how the patient responds. And so whether it be a flexion or extension, I also believe that physios, we've missed out on the fact that there's two other planes of motion that actually happen in the spine. You have lateral flexion, so side bending, and rotation. And the thing is the fact that the majority of practitioners, and it's not just physical therapists, it's actually even if you see it on the internet or McKenzie-based people who are saying that they're doing McKenzie press-ups, is that they're going to focus entirely on extension, 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 where in some cases, these patients might actually need more of a flexion-based approach, or they might actually need more of a side bending approach. And really, if it is going to be side bending, it's only going to be specifically one motion that they're going to prefer. They're either going to prefer side bending towards the side of pain or side bending away from the side of pain. And the same thing when it comes to rotation. And I remember early on in my career, my mentor said, Ashley, if you've exhausted sagittal plane motions, if you've done so many flexion-based activities, it doesn't have an impact. You do extension-based activities and it doesn't have an impact. Or it turns out that both of those motions actually increase the pain. It's time to move on to a different plane of motion. And I think it's important for people to understand that McKenzie wasn't just back extensions. It was really being able to say, all right, yeah, it turns out that back extensions do help because the majority of us, in fact, do sit for a long period of time. But there's so many other spinal motions in it. And I think it's important for people to understand that.
Nice. Now, this is a new perspective which I've learned today because till then we are using only McKenzie extension. But since the spine has rotation component also, So that's one of the main important aspects which we have to work on. That's nice. I learned something new today. And now, when we get in terms
Oh,
of
thank you.
acute and subacute, do you still categorize pain in terms of acute, subacute, and chronic, or will we go have to go in terms of IASP model of only acute as well as direct chronic? So there is no subacute now. So if someone comes with an acute sciatica, what should be my immediate
Correct.
perspective of how I have to plan versus someone with a chronic sciatica?
Uh, I want to make sure I heard that correctly. So, how do we plan out if someone's dealing with more
More acute,
acute sciatica versus
chronic
chronic
sciatica. Yeah.
sciatica? Okay. Absolutely. Yeah, and I agree. I think it's important for us to be able to truly delineate the difference between the two because anything shorter than 12 weeks, we're looking more at an acute sciatica pain. It's during that acute phase where we're actually dealing with inflammation and actual tissue healing. So there definitely is a role, there definitely plays a role in being able to reduce inflammation to protect that joint. Because of the fact that with any sort of actual tissue trauma, you are going to, in fact, have healing happen. And with healing comes inflammation. Oftentimes, the inflammation will cause areas to swell and put pressure on the surrounding nerves. And so, absolutely, there's going to be a pain associated with that. So, in the acute stage of pain, I think it's important for us to actually understand that it's really more so protecting the area, but also, and when I mean protection, what that means is avoiding the activities that actually increase the pain. So, say if someone is, say, if a patient recently started dealing with sciatica pain because they bent over and picked up their shoe from the ground and their pain started to come on, I would want to identify, well, why did that happen in the first place? Were they lifting with suboptimal mechanics, or were they fatigued or tired? Trying to understand what was the scenario. But then also at that time, we need to ensure that we're going to minimize opportunities for this patient to bend over because we know that that was the irritating stimulus. So we either do one of two things. We actually either tell them to not bend over for the next couple of days, or the other option is to say, this is how you can safely bend over. And then from there, we monitor and assess the 12-week process to be able to see, let's slowly introduce the movements and exercises that feel safe to the patient with an emphasis that we are not eliciting or increasing the pain that the patient is dealing with at that time. We are a little bit more careful in regards to trying to identify when it comes to implementing exercises, but we are not fearful, really creating a safe environment. And but we are also understanding that there is true actual tissue healing involved. Now, when we transition into the chronic stage, at that point, the majority of tissues that need to be healed are healed. And we're not necessarily dealing with high levels of inflammation unless this patient is, in fact, dealing with what we call systemic inflammation, where the whole body is going through some sort of chemical process. If they've been dealing with chronic inflammation for a long period of time, that's an entirely other additional question that we need to ask. Why are they going through such widespread inflammation? And that's where we have to look at diet, sleep, stress management. But outside of that realm, when the patient is dealing with pain still past that 12-week mark, what we have to identify is, well, why is this the case? Because we know that the tissues that need to be healed are in fact healed. So it could be due to a couple different reasons. Number one is the fact that they're still doing the activities that are irritating their pain in the first place. I like to allude pain kind of like a scab. You have a scab, you have to make sure that you don't touch that scab so the skin can heal underneath it. When your skin heals underneath it, the scab will fall off. You can go back to just putting pressure on that piece of skin. When you have a scab, but you constantly irritate it, you pick at it, it starts to bleed again. It is painful as well, and it actually will delay healing. So we have to figure out, is their everyday activities, are they actually causing further irritation? Are we picking away at that scab? And if that's the case, what we need to do is actually, again, go ahead and break down what are those activities that they're doing that is actually resulting in the fact that their pain isn't resolving. That's going to be number one. Is be able to, we're looking at activity modification. That's going to be number one. But also number two, I'm also going to premise with the fact that whenever someone's in an active state of pain, aka if they're in pain just sitting, even listening to this episode, their plan, whatever exercise or stretch that they're doing, should be focusing on actually bringing that pain down. I think one of the challenges is that we're dealing with pain, whether it be acute or chronic, and we're given a whole bunch of stretching or strengthening exercises that aren't necessarily dealing with the symptoms themselves. They might not necessarily make them worse, but they're definitely not making them better. And I think one of the challenges is that if you're dealing with mechanical pain, as in your pain can be influenced by something, if their pain can be increased by one thing, it can be very, very likely be reduced by doing something completely different, perhaps even the opposite. So I think that's an important part. But so, we have the healing scab from a chronic standpoint. We need to ensure that we're not constantly irritating that area. But then the second part is that when you're dealing with chronic pain, you got past that 12-week point, our nervous system, our brains are actually conditioned to feel that pain. And that pain itself doesn't always mean that there's something that's actually damaged. Maybe there isn't a scab. However, our brains are so used to feeling this pain to protect ourselves from doing day-to-day activities because our brains and our bodies are scared. And once we can rule out that there isn't necessarily a mechanical issue, as in that we can't address, as in we can't address what movements are going to make it feel better, or can't address the movements that are making it feel better. And it turns out that we're actually dealing with more of like a nervous system conditioning. We call it nervous sensitization. It's at that point where we have to start, in a way, pushing our patients, but in a way of not pushing, more so guiding our patients into understanding that the movements that they're doing are not painful and they're not dangerous. So at that time, we're actually going to be focusing on reducing the fear of motion. And reducing the fear of motion will, in essence, reduce the level of pain that people will be dealing with as well.
Nice. And continuation for the previous question. So you have mentioned regarding long-standing pain. So our brains start catastrophizing thinking. So they go in terms of the magnification and all those process. So now if someone has a long-standing chronic pain, say because I get patients with 3 years, 4 years, the MRI will give us report saying that L5S1 or L4 L5 issues of disc bulge, but it is a long standing since research also says that the disc is going to heal in some time. We get the shadow of the MRI present there in terms of the MRI itself. But people were so influenced by the MRI reports itself, they believe that even the discs are still present there. So the discs have come out, that bulge is still kind of fresh, and they have still these issues of injury. So, how do you see the magnification role of our brain? So, you have mentioned that stress management could be one particular pattern. So, the role of magnification, if we identify magnification, what are the steps that we have to see in terms of referral pattern? Because we physios are not experts in every areas. We are experts into certain areas. Say in terms of rewiring or behavioral modification, we don't play a major role because it is not our domain. So, how to identify someone who has magnification or who has catastrophizing thoughts?
Yeah. Okay. I want to make sure I heard that correctly, just because it was a little cut off. Um, are we saying how can we actually determine, is the patient that we're working with, are they dealing with something more of like a magnification versus a
Yes,
mechanical
correct.
issue related to
Yeah,
their pain? Is
yes,
that
yes,
right?
it's correct.
Okay. Absolutely. So as physical therapists have been trained to be able to read and assess and collaborate with our patients, there are definitely a lot of things that are really more so outside of our control. I think one of the really beneficial things about ruling out red flags is that we have a clear set of criteria that actually helps us identify, okay, are we dealing with a true medical red flag, right? But the good news is that by the time they come and see us, they probably have gone through the entire gamut of red flag screening. So it's actually a very, very good thing, the fact that they don't have a medical red flag. But on the second part is from a magnification standpoint, how can we tell that what they're dealing with is actually related to either the stress or things that they've been dealing with specifically? And it's going to be a multimodal approach, because the reality is that we shouldn't be addressing these, we shouldn't be addressing, say, the exercise and stretches or hands-on modalities. We shouldn't be separating that from the education and pain education part of it. They work hand in hand.
Yep.
And it's important for us to recognize that when you have been dealing with pain for a long period of time, 12 weeks or more, it would be safe to assume that our attitude towards the pain and towards our recovery process is going to be different now compared to when we first hurt ourselves in the beginning. And then from there, it's important for us to recognize, how can we see those patterns? What are these patterns of pain that we're dealing with? And I think it's important for physical therapists, physios, chiropractors, physicians to be able to say, well, tell me a little bit more about this pain in regards to how does it behave either throughout the day. And luckily for us physios, we can see patients a little bit more often, and we can see what are the patterns. Is the pain more elevated at the time that there are high periods of stress? Or we may notice is that if we have a flare up, what are our reactions to the flare up? And that actually will help identify, okay, these are some of the invisible factors that are at play when it comes to managing pain. And I've seen this a lot in the patients where I'll have some patients who've been dealing with pain for a long period of time, but then they'll get a flare up. But then they'll say, Ashley, I have a flare, but it's okay because we know the strategies that we need to do to get it fixed. And then the other end of the spectrum, we'll have patients who are saying, Ashley, I have a flare up. I think the world is burning to the ground. I'm so scared. I feel like I'm going to be living like this for forever. Why is this all happening to me? So we can put in some entry level psychology, especially from a pain management standpoint. But I think it is important for us to ensure that there needs to be a line that's set when someone is being so anxious or so preoccupied with the level of pain and with the stress that they're going through, that will have an impact. And I think it's important for any provider to actually have partnerships with other mental health providers, because they can provide something that we absolutely cannot provide, and vice versa.
Nice. So now most of my students, so I'm a teacher here, so I teach people in terms of low back pain evaluation and therapy. If someone's want to make a niche like you, so if they wanted to become some low back pain expert, what are the steps that they have to take from beginning? If they have any plans of becoming an expert in one certain field, either in the low back or in anywhere. So if they are into postgraduates now, or if they are into the bachelors, in India we have bachelors as well as we have post graduation. So 4.5 years is bachelor's and 2 years is the post graduation. So if they wanted to become an expert in future, what are the steps that they have to start, and how should they start?
It's a it's a powerful journey that you can go on. Being an expert in something doesn't mean that you can't work with other conditions or other challenges. I know that my focus is sciatica pain, but I'm working with people who have neck and shoulder pain, carpal tunnel, knee pain, hip pain. And so I think the number one thing is understanding that if you want to be an expert in something, you don't necessarily can't work with another condition. So I think that's number one. Also, number two, I think what's really important is the fact that you have to have you have to have a track record. You have to be able to know that what you're providing is in fact helpful and that you are helping people in that specific realm. I think it's a huge challenge, especially in this day and age, where people can market themselves as an expert, yet don't have the track record or understanding of how to fix things. And I think it is important for us to recognize that you have to know that you are helping someone, you're helping a lot of people before you start saying that you, in fact, helped a lot of people with a specific condition. So identify what you're good at and pursue that. Work with more people along that specific condition, measure your progress, can constantly question yourself in regards to, could you have served that person better? Could you have served that person faster? And from there, once you notice that you're feeling more and more confident of actually being able to treat a specific condition, that's where I think that you can actually say that you're an expert. The word expert is just a word. Being an expert doesn't mean that you know everything, but being an expert means the fact that you're able to recognize what you can and cannot do. And I think that's extremely important. So rather than saying I can help everyone, it's important for you to recognize that you can focus on helping a specific subset of people, but then also know that you can.
Thank you. And what are the urgent therapies you use in your therapies usually? What are the other agent techniques you use apart from exercise, electrotherapy? Anything else you are going to use in your setup?
Yeah. So, in regards to treatment modalities, right? Treatment modalities or tools. I think the most important is, in fact, exercise and movement. But I think it's really, rather than saying just general exercise and general movement, I think it's important to actually be able to do a couple of different things. Number one is exercise selection. Again, when people are dealing with pain, every aspect of their program should be reducing their pain or actually preventing it from getting worse. That's going to be exercise selection. The second part is going to be dosage. And I think dosage is important to be able to say, are you doing enough? Are you not doing enough? Or are you doing too much? It's important for us to understand that in some cases, patients are going to get better with just doing 3 to 5 repetitions, but then also understand that people are going to require 30 to 40 repetitions to actually experience a change. So that's going to be from a dosage standpoint. Also, that also determines the level of intensity as well. Do they need to add more weight? Do they need to add less weight? Do they need to hold a position for a longer period of time? And then the third piece of that is not only like exercise selection, exercise dosage, but also looking at, are they going about their normal day-to-day activities with the optimal mechanics? As in, are they doing things that are not going to be further irritating their pain? And I find that actually particularly useful in my line of work because the majority of the people that I do see, they're virtual. And because they're virtual, I don't necessarily have much of an opportunity to put my hands on them, which means that if they've gone through 3 to 4 physios before me, they've gone through the entire gamut of hands-on care, oftentimes there's a missing piece of the puzzle. And I find that that is the missing piece to the puzzle. However, I will say I'm located out here in California and I'm just north of the San Francisco. And if I am seeing patients in person, a couple of other modalities that I will use, we'll do some hands-on massage or manual therapy. I think that massage is a form of manual therapy, but a lot of times people think like they're getting manual therapy and it's just some soft tissue work. So I think that manual therapy is categorized into a couple different pieces. You have soft tissue work like a massage, but then you also have joint mobilizations, being able to move the joints not just in their range of motions but beyond. We're looking at 2 types of motions. We have physiological motions, which is like, say for example, your elbow, it bends and it straightens. But then we have what is called physiological
Anatomical.
and accessory motions. And accessory motions is going to be the rolling and the gliding of a joint, and that actually occurs in both the back and other parts of the body. And then the third component of manual therapy is actually going to be, which often gets either overutilized or underutilized, is we call it neuromobilization, to actually move the nervous system and stimulate it, to be able to either apply a stretch or apply a glide. This is stuff where you're talking or you're hearing about, say, like sciatic nerve flossing or sciatic nerve flossing done with physical therapists' assistance. So rather than actually having to put yourself into the stretch, you're passively put into that position, and that in itself can have an impact.
Yeah.
And then the third, another component that I'll use is I'm actually a huge fan of like stuff like kinesio tape, whether it be kinesio tape, rock tape, or any other stretchy adhesive tapes that are out there. I'm a huge fan. I know that the research doesn't necessarily show that they do what they exactly do, but I really think that there's a huge component to the sensation of touch. Being able to just provide a little bit of guidance or what we call kinesthetic awareness to a specific body part with the use of tape. I think there's a lot of value in it. While I say that tape is going to be something that's going to fix everyone, absolutely not. But do I think it's going to be a good way to help support a joint or a body part? Absolutely.
No, because we usually have the conflict as a researchers. We have to see whether it is research based or whether it is in terms of therapy induced. Because like we had found one issue in kinesiotaping itself. So research says it is not useful because the systematic reviews or whatever reviews we see Cochrane, they said that the p-value is not that great, the forest plot is not that great. But when we actually use it, like how you have mentioned the touch, the tactile sensation, everything, people have the perception of that if there is any touch there, the pain subsides. Likewise, we had issues with needling also. So research may not augment that, but sometimes if you see into case to case basis, on person to person basis, we may have lots of difference of these agents because we identify dry needling and we identify kinesiotaping. Sometimes we identify other agents which is going to be very very easy and that suits patient's pain. So this is one contradictory thing which we find in terms of research as well as on a real life clinical basis. Because what we believe is from research to clinical practice, it may take time because whatever we are trying to plan, it is like 10 years behind. So the research when it comes to 10 years, there will be new technique coming up. Like we have cupping and other things. So it's like emerging
Yeah.
trend. So there is no fixed criteria saying that this has to be followed throughout. So that's the issue which we face in terms of research to clinical practice. So there's one thing which we are facing here also, exactly. And anything else, Doctor? Actually, you would like to
Yeah, I
tell our
agree. I
viewers?
think that
Yeah, please continue.
yeah, I'm gonna just add one quick note to the research aspect because I think you bring up a very valid point. I think what's really interesting about research is that it gives us the opportunity to see are these things actually in fact truly helpful. And I think what's uh, one of the limitations when it comes to research is the fact that we're trying to answer a specific question, right? And so the thing is that when we're trying to answer a specific question, we have to figure out there's a lot of different ways for us to actually answer the question. And I think a big challenge, especially when it comes to dealing with pain, is the fact that because pain is such an individualized experience, it is a little bit more challenging to be able to apply various different techniques for treatment in the pain science realm, especially with something like, say, non-specific low back pain or even something like sciatica, because of the fact that, like, say, for example, we I'm just going to create a hypothetical scenario, but we want to take a look and see if actually prone precepts are in fact helpful for centralization of patient symptoms dealing with a lumbar radiculopathy, right? And so here you have these patients who are presenting with the same type of clinical presentation, radiating leg pain, which originated at the spine, right? But what's really interesting is the fact that okay, that's the criteria. We also have to roll out red flags and also ensure that yeah, we're having that the patient's dealing with the pain for about say 3 to 12 months, and so we put them through say a prone pressure program. I think one of the challenges is the fact that you can have patients who present with the same symptoms but have a different cause of pain, even if they have the same
Yeah.
MRI, right? How many patients have you seen where they have a posterior lateral bulge at the right L4, L5, yet they actually respond positively with spinal flexion instead of a press up, right? And so if you have those patients who are in that, right, having that, and it's really kind of luck of the draw, right? And being able to say, all right, well, in this current cohort, turns out that everyone responded to prone press ups. And what ends up happening is we take that research and then we apply it to our current clinical practice. And then we start getting frustrated because of the fact that it wasn't the case all
Yeah.
along. Right. And so, and I think this is the same thing when it comes to other modalities. But I mean, there for sure is, some very quite definitive research in regards to knowing that, say, electrical modalities or ultrasound don't necessarily actually benefit our patients who have back pain or sciatica issues as well, because we know that unless it's not mechanical in nature, there's something that we need to look at and address.
Thank you so much for your perspective. So we'd like to give a quick note to our audience, who are mostly students.
A quick note, yes, I would say who are mostly students, I would say continue to focus on taking care of the patient who is right in front of you. Do your research, which helps you truly determine what's going to be the best for your patients. I think it is important that, yes, we all follow some sort of systematic process, but you also have to understand and go in with an open mind and be ready to make changes if your patient isn't responding, and continue to focus on healing the world.
Thank you so much, Dr. Ashley, for accepting our invite and coming to the podcast. So we are looking for forward podcast because since it is a small one, so we were just giving a random things, and it was like only on sciatica. So we have few questions regarding your I fix your sciatica aspect also. So in the future consecutive podcast, we would like to ask those also. And thanks you for accepting our invite and coming to the podcast. So looking forward, Dr. Ashley. We'll meet up again and we'll have further more podcasts. And regarding this to my students, I would like to importantly inform that all the concepts what Dr. Ashley has explained will work for our clinical scenario also. So because since we are physical therapists, it's evolving. We have to be a lifelong learner. And in the last week note, he has mentioned that it should be in terms of case to case basis. Means we have to see all individuals as unique. MRI is an adjunct, but we are not going to treat MRI. We are going to treat people who are there with pain and suffering with pain. So we have to take these considerations and we have to manage people with pain there. And since it's not an expert, you can be interested in one particular area, but we have to keep on treating all the musculoskeletal conditions. So that's a takeaway from this podcast. And thank you, Dr. Ashley. We'll meet up again.
Thank you.
One second, I'll just turn off this.